Well, thank you, Peter, for inviting me. So today I chose this topic because I thought that it may be, of value in terms of observational research in urology, and I'll use some urology-related examples as well. So let's just briefly talk about the differences between randomized trials and observational studies. So we know that randomized trials are the gold standard of medical research, and that's mainly because of the act of randomization minimizes a lot of the biases that we would otherwise see in non-randomized studies. And this is contrary to observational studies where we actually deal a lot with different types of biases. And again, this is mainly because of the fact that these studies are not randomized and prone to other biases. And the three main types of biases that we deal with in observational studies are confounding, selection bias, and measurement error, which is sometimes called information bias, or exposure or outcome misclassification. And so measurement error can occur in either measuring the exposure or the outcome or any of the covariates. So bias is a very complex entity, and it would be great if you could actually visualize it and look at its structure when designing studies or when reviewing other studies, to have a better idea of what these biases are and how to control for them. And this is very similar to, let's say, a leak in a house where a blueprint of the piping can help a plumber actually pinpoint where the leak is. And so using causal diagrams, we can actually do a similar approach where we can pinpoint where these biases are so we can better control for them. And that's, that brings me to the topic of causal diagrams, or causal directed acyclic graphs, CDAGs for short. And these are mathematical graphs that actually have been used for many years in computer sciences and mathematics, and there are mathematical proofs behind them, and they have kind of found their way in epidemiology and medical research in the last few years. Just some sort of rules and definitions on how CDAGs work. So basically, these are a group of letters and arrows, and so the letters or nodes represent a variable with an arrow showing a direction of a causal link, and we all, an arrow connecting two variables is what we also call the path. So x causes y, and there is a path where x is causing y. We also have other sort of structures that are important to cover today. So a variable that is a common effect of two other variables, we call that a collider. So z is a common effect of x and y. And a confounder, that's actually a main structure of a confounder, is a common cause. So z is a common cause of x and y, and z here is a confounder. So what we can do is paths are open, which means that flow of information is going on, and we can close these paths by blocking the paths. And so we'll talk about what blocking is, but before that, we'll sort of talk about what we mean by conditioning, because when we block a path, we're actually conditioning on that variable. So conditioning in epidemiology refers to holding a variable to a specific set of values. And so I'm sure you're familiar with different forms of conditioning. Matching, for example, is a very well a popular conditioning technique used in case control studies. Stratification is when we condition on a variable as well. Restriction is also a form of conditioning because we are only restricting the analysis to one set of variables. And probably the most commonly used technique for conditioning is statistical adjustment. So again, matching is very popular. So you can pair match cases and controls by different, whatever variable that you choose. It's usually age or sex or comorbidity score that's matched. Stratification again is a way where we can, if we suspect, for example, in this case, age seems to be a confounding variable. So if we stratify, we'll see if we stratify by cutoff point of 50 years, we'll see that the relative risks are different, suggesting that there's a confounding effect of age in our global data. And again, the most commonly used type of conditioning is a statistical adjustment because it allows us to condition or adjust for multiple variables at the same time. So let's talk about confounding bias, which is probably the most prevalent type of bias that we see in these studies. So confounding is created by a confounding path. So again, a common cause structure. And a confounder is a variable that is a common cause of outcome and exposure, or also a variable that can be on a common cause path. So there are examples where the confounder identifying the confounder is not clear cut, but you can identify a path that can cause a confounding effect. And let's just go over an example that's non-medical as well. So, for example, we know that many drivers involved in car accident on rainy days may have an umbrella in their car, but does that mean umbrellas can cause car accidents? And of course, that's the answer is no. And if you see the causal diagram, there is really no arrow between umbrella and car accidents. But you can see why people may associate that with umbrella use with car accident, and that's because of through a confounder, which would here be rainy weather. We know that rainy weather is associated with car accidents, and people carry umbrellas on rainy days. So rainy weather is a confounder, and if we adjust for this variable through the techniques that we talked about, then you would see no association between umbrella use and car accidents because we block the path of a non-causal association from umbrella use to car accidents through blocking the path on rainy weather. So let's look at an example in urology. So androgen deprivation therapy has been in the literature quite a bit, and one of the outcomes that they have looked at is Alzheimer's disease. And so this was a study in New York, a cohort study that found an association hazard ratio of 1.88 with ADT use and Alzheimer's disease. And now we also know that in these men, cognitive performance is a confounder. And in fact, studies have shown that the cognitive performance of men using ADT may actually be lower than those not using ADT. So then cognitive status is definitely a confounder that has to be adjusted for in this study, which was not in that previous study. And again, you have this typical causal diagram of a confounder where cognitive status is a common cause of ADT use and Alzheimer's disease. And we can adjust for this again, through different techniques of matching men by same sort of a cognitive score or a stratified analysis.
Mark, can I just interject? Go back one slide, just because I'm not sure. No, one forward. Sorry, forward, not back. There. So why is it that you've got the arrow for cognitive status pointing towards ADT when ADT is the common cause of cognitive status rather than cognitive status being the common cause of ADT? So can you just clarify that?
I was just going by this this specific study that showed that cognitive status is lower in patients with ADD, so there could be an association with ADT use.
Yes, it's been established, I think. Okay, so I think that we all agree that there's an association. You start ADT, cognitive status is affected. I just wonder why the arrow is pointing in the direction of cognitive status to ADT. Why is that a standard nomenclature in your domain?
Right, I understand your question. So again, it may be possible that men with either lower or higher cognitive status could be more likely to get ADT, especially if there is, literature that it may improve Alzheimer's disease risk. So just specifically on this context.
Martin, the study that he showed on the slide before says men have lower cognitive status before starting ADT.
Okay, that's what he's
which I've never heard of before.
I've never heard of that either. Yeah.
And again, this is just an example to show confounding. I haven't done a systematic search on exactly what the relationship is between ADT, Alzheimer's disease, or cognitive status, but just to show how a confounding structure would work. So confounding can actually present itself in different sort of shapes and forms. So one form, so what I showed you is the typical common cause confounding structure, but it can also have different forms. And one of those forms is what we call healthy user bias. And this is where subjects who are using a drug or a supplement are also involved in healthier lifestyle, which puts them at a lower risk of developing the outcome, usually cancer or prostate cancer. So it confounds the effect of the drug or a supplement in favor of a protective effect with the outcome, when in fact it's the fact that they're a healthier group experiencing less events. And again, one example is, we've seen a lot of studies on statins and prostate cancer, and a profound protective effect of 62% reduction in relative odds when using statins and prostate cancer. And again, just in the context of a healthy user bias situation for this study, we can draw that diagram. So again, a lot of the limitations of these studies is what we call an unmeasured confounder, which is healthy behavior. And healthy behavior cannot be quantified in these studies. It's not a quantifiable entity. And that's why a lot of these studies are subject to biases that cannot really be controlled. So if we draw the causal diagram for this sort of bias, you have U, which is an unmeasured confounder, because we know healthy behavior associated with prostate cancer and also statin use, but also physician visits. So we know that healthier patients or healthier people, more health conscious, are more likely to visit their physicians. And they're more likely, once they're in the office, to get a statin prescription. So here is a situation where, although we have to control or adjust for U, usually we don't have U. but we do have, again, usually we have data on number of physician visits. So if we actually block or adjust for MD visits, in a way we are closing this confounding path through MD visits, even if we don't have our unmeasured data on our unmeasured variables. So again, the causal diagram can help us identify areas that we can adjust for to close the confounding path, even though we may not have data for that specific confounding variable. So the second major bias that we face in these studies is selection bias. And I call it the other man-made problem because unlike confounding, where we are sort of dealt with a lot of confounding variables, especially unmeasured confounders in our data sets that sometimes we can't really do anything about because we simply don't have the data. Selection bias is a bias that is created by investigators and it can easily be averted. And so if we look at the structure of selection bias, and we call this, a fancier term for this is collider stratification bias. So again, confounder was a common cause situation. Here we have a common effect situation. So Z here is a collider because variables X and Y collide on Z, and as it stands, Z is actually blocking any sort of flow of information from X and Y. But when we condition for Z, the opposite of confounding happens. So it actually opens this path, this unwanted path between X and Y. And that's when selection bias can occur. And so again, if we look at this, an example here. So imagine an investigator wants to look at the risk of erectile dysfunction and prostate cancer, and they are interested in stratifying the results by the number of urologist visits, just to see whether men who have visited a urologist more often are at a different risk. And they see an unexpected association. What can be one plausible explanation? So again, in the simplest form, so you have erectile dysfunction, and you have an arrow to urologist visits because men with ED are more likely to see a urologist, and men with prostate cancer are also more likely to see a urologist. And so as it stands, again, there is no arrow between ED and prostate cancer. And as it stands, if we know a man has ED, we really don't know anything about whether they have prostate cancer or not. But if we condition by urologist visits, and again, conditioning means setting, sort of pinpointing that variable on one set of its values. So if we know, for example, erectile dysfunction, a man has ED and has visited a urologist, it's easier to guess that they may have prostate cancer. So that's how these correlations occur in selection bias as a result of conditioning on a collider variable. And again, another example of ADTH in Alzheimer's disease. So this, just like confounding that has different shapes and forms, so does selection bias. So one form of selection bias is called survivorship bias, that can be shown in this specific study. So in this study, what they did is that they identified men with prostate cancer, and they and some of these men obviously had prostate cancer and were just followed where they were receiving no ADT. And that's a period of, the dotted line is a period where they were unexposed. And then they get ADT at some point. And the men in the control group, obviously, they don't get ADT and they can die at any time. So what these investigators did is that when they wanted to look at the follow-up of the ADT patients, they only looked at follow-up from the start of ADT initiation, which is which basically meant that they excluded all the unexposed person time, all the person time that a man was basically unexposed was excluded. And so this biases the study toward men who have survived to get ADT, causing a survivor sort of a bias happening. And if you want to look at this structure, it looks something like this. So S is a variable which basically stands for having been selected into the study. When we draw a square around S, it means we're conditioning on that variable, meaning that, again, we're opening this path. Again, one of the reasons these biases happen is usually because of an unmeasured confounder, in this case, cardiovascular severity. So when we open this path, again, we have an open path that causes a non-causal association between ADT through an open path from S to cardiovascular disease and Alzheimer's disease. And this bias is also called immortal time bias because it refers to a period that somebody cannot die and is included in the study. The fact that they can't die in that period causes an artificial sort of survivorship in that study. Selection bias also occurs a lot in hospital-based databases, and it's referred to actually years back as Bergson's paradox or fallacy. This happens because, again, hospital patients are sick, and a lot of things can happen in terms of bias when these patients are studied. So, again, in this situation, let's say that one wants to look at the risk of finasteride and stroke. And we know that there is really no risk associated with that. But if, let's say, an investigator wants to look at this in a hospital setting, and I know BPH, is relatively a benign disease, but there could be complicated cases in hospitals. So I have an arrow from BPH to finasteride, and an arrow from cardiovascular disease to stroke, and both arrows to hospitalization because they can lead to hospitalization. But again, as it stands, any path between finasteride and stroke is blocked through H. But when we actually do a study in a hospital, conditioning on hospitalization, we are again opening this path that now correlates finasteride and stroke through an open path through H. So finasteride now becomes associated with stroke through finasteride, BPH, hospitalization, CVD, and stroke path. And this is called, actually referred to as M bias because it looks like an M, and it demonstrates how selection bias can occur using hospital-based studies. So in summary, causal diagrams can be helpful. I'm sorry. I think there is one more. Actually, I'm going to exclude this slide and just go to strengths. Causal diagrams can be very helpful in sort of showing us the structure of biases in observational studies, certainly to control for confounding, and certainly to identify areas where selection bias can occur. And of course, this can be very helpful in improving validity of observational studies, which, as you know, may have taken a bad rap in recent years, simply because of contradictory results of different therapies. And this perhaps could be one way to improve the strength and the validity of these studies. Of course, there are limitations as well. So one major limitation is that if you don't know your topic well, and if you cannot identify all the shared causes that go into that topic, then it's it may lead to bias because you're missing critical shared causes on a specific question. The second limitation is that although we can pinpoint biases, we can't really, from these graphs, sort of estimate or infer any direction or magnitude of the bias. The other limitation, again, is sort of not knowing the data or the topic. So there are a lot of situations where you don't know if variable A causes B or whether variable B causes A. And in these situations, it's recommended that maybe investigators can actually have multiple scenario DAGs and just see how things work with positioning different variables in question differently in the DAG. So what I showed you were really simple sort of structures just to kind of show the a conceptual framework of how these biases work. But in real life, this is, it can get quite complicated actually. So this is a published study looking at statins and COPD, and I'm actually showing you a sort of a shortened version of it because obviously variables like age should be here, but they're not because it just made it even busier. Again, just to show you that it can get complicated when you actually do these graphs for actual studies. And I'm happy to answer any questions if you have any.